In this video, I'm going to briefly run through the typical clinical evaluation of a patient who's suffering from a dysautonomia such as POTS, orthostatic intolerance or frequent fainting. The symptoms can be quite significant. Patients will report a lot of fatigue, palpitations, lightheadedness, dizziness. There can be post-exertion malaise, poor sleep, brain fog, ongoing fatigue. Symptoms that really can have a significant impact upon the quality of life. So the first step when a patient is experiencing symptoms like these is for them to have a clinical evaluation. Now it is really important that the person who is performing the clinical evaluation has an understanding of the autonomic nervous system and how to manage the disorders of the autonomic nervous system. The patients will need to be given a clear explanation as to why they are experiencing their symptoms, and if they do have a dysautonomia, this should be established based on the clinical evaluation and perhaps some clinical diagnostic testing. So the first thing is to go through the history. It is important that there is an individual approach because the symptoms of a dysautonomia can be quite variable and not every patient will experience the same symptoms. Also, it will matter what your baseline level of activity was before the onset of your symptoms. It'll need to be established how your symptoms came on. Was it quite suddenly or was it a little bit more subacutely, like over weeks to months, or was it over a longer period of time? And it is also really important to establish whether or not there was some kind of trigger for the symptoms. So often that can be a viral illness, a recent surgical procedure, especially if it was major abdominal surgery, for example, recent pregnancy, if someone had a concussion. So all of these things are quite important to establish, but often there is actually no clear trigger for the symptoms that the patient is experiencing. So all of these things will need to be established in this clinical evaluation. It will also be important to look at your medications to see, firstly, are there any medications that might have triggered your symptoms or just worsened your autonomic function and brought symptoms about. So for example, if you were someone who had occasional fainting episodes in your teens, or when you were younger, you would have experienced like lightheadedness, let's say around your periods, or something like that, and then they represent in later years. Sometimes that can just happen, but sometimes it can be triggered by a medication, because some of the medications used to treat migraine or anxiety, for example, do have the potential to let's say change the autonomic control of your blood pressure and heart rate. So it's just important to go through that and make sure that any medication you're on is kind of clearly established during your clinical history. It's also important to talk about a family history. It's not necessarily that these conditions are genetic, but they can run in families. So it is important to look at whether or not other members of your family have suffered from similar symptoms over time. Then when it comes to the detail of the actual symptoms you're experiencing, it's important to try and see which ones are orthostatic related and which ones aren't. So by that I mean there are a certain group of symptoms that patients tend to report, in particular when they go from sitting or lying to standing, such as palpitations, lightheadedness, dizziness. Some patients will experience a profound sense of fatigue when they stand up. Other symptoms that can have an orthostatic component, but less commonly than, let's say, palpitations or lightheadedness, would be headaches. Some people describe a coat hanger headache, so that's a headache that might be across the shoulder region. Sometimes patients get nausea when they stand up. So it is important to establish which symptoms are orthostatic and which symptoms are non-orthostatic. So patients with POTS and orthostatic intolerance will often also report a lot of gastrointestinal symptoms, brain fog, unrefreshing sleep, and these symptoms aren't necessarily relating to the change in position. So these symptoms are more likely just coexistent as opposed to caused by the dysautonomia, but they are really commonly reported in patients who have a dysautonomia. but it's important just to distinguish between them for the patient, because some of the non-orthostatic symptoms may not respond so well to the treatment of the orthostatic symptoms. So if you look at my video on the kind of lifestyle and non-pharmacological interventions and the pharmacological interventions, a lot of them are targeting the symptoms that are specifically relating to changing the position. So it's not that these other symptoms can't be treated or won't be treated, it's just they'll be treated differently. And it's important that the patient understands that the non-orthostatic symptoms won't necessarily respond to the orthostatic treatments. The next thing to kind of talk about are the triggers. So a lot of the management of a dysautonomia or these kinds of symptoms would be lifestyle related, or just kind of trying to identify triggers and then try to manage them. So for example, dehydration, a really warm environment, having your period, having any kind of viral illness or infection, all of those things can be a trigger for symptoms of a dysautonomia. So it may well be the case that if you know you're going to be dehydrated after, let's say, a very heavy exercise session, that you would have significant hydration taken before you exercise and significant hydration taken right after you exercise, and you might find that that buffers a symptom and you don't experience it so much. Another example might be if you know you're going to go on a sun holiday and you know it's going to be really warm and you're likely to be more dehydrated, that might be a time to bump up the salt and water in order to kind of mitigate for that particular symptom. So it's well worthwhile talking about the triggers of your symptoms, because there may be practical ways of managing them, and a lot of patients would rather avoid medication, and this is one way of trying to avoid medication. So once you've gone through all of that and we've established, you know, whether or not your symptoms sound like POTS or orthostatic intolerance, or they don't, or some symptoms do, some symptoms don't, and you've had a discussion about how we could potentially manage the symptoms, then we can think about whether or not you need any further investigations. So the basic lab tests, like your full blood count to make sure you don't have anemia, iron levels, vitamin B12 levels, thyroid function, would be fairly standard testing to be done. And then there can be more specialised testing depending on the kind of symptoms you have, such as autoantibody testing, or testing for neurotransmitter or hormone levels. They may also be worth doing in a small subset of patients. One kind of testing that I would recommend most patients have would be cardiac testing, and that is because sometimes the symptoms of a dysautonomia overlap with cardiac symptoms. So it's worthwhile having a 24-hour blood pressure monitor, a 24-hour Holter and an echo, because this just gives an overall evaluation of the structure and function of the heart. And it's also worthwhile because a lot of the medications can affect these things, so it's nice to get an idea of what your baseline level of function is. So if you can get those testing done, then that's definitely not a bad idea. It doesn't preclude you from trying the medication for dysautonomia or engaging with the exercise program, but it can be worthwhile doing, or at least having a clinical evaluation to see if you need them or not. A test that I frequently do on patients is called a tilt table test. I find this really useful. What we do is we have a patient lying down, they have a finger blood pressure monitor, and they have another blood pressure monitor in their arm, and they have a heart monitor, and we essentially evaluate the response of the autonomic nervous system to an orthostatic stress, which is essentially standing up. So they're on a tilt table, which is basically lying flat, and the table is just tilted to 70 degrees, so you're kind of almost standing, but you're not quite standing. So by doing that, you're kind of eliminating the muscle pump part of the being upright, and it is a good stress of the autonomic nervous system. It is useful doing this because even in patients who don't necessarily reach diagnostic criteria for POTS, we get to see what actually happens to their blood pressure when they're challenged. And I have certainly seen patients whose blood pressure have fluctuated a lot throughout the test, and the heart rate has been responding to it throughout the test. So in that kind of a clinical scenario, the test gives a lot of useful information even when it doesn't necessarily reach diagnostic criteria. So that's just a quick run through of the clinical evaluation. One thing I forgot to say during the first part of this was that other associated conditions like the hypermobile joints, part of Ehlers-Danlos syndrome, mast cell activation and coexistent migraine are other things that will be checked for in the clinical evaluation. So I hope that's of help.